Good afternoon, everyone, and welcome to our webinar, which is Driving Action in Neighbourhood Health. Thank you so much for joining us this afternoon. Today, we're focused on neighbourhood working and how we can shift from organisational silos to genuinely patient-centred, integrated care, supported by digital innovation and strong local collaboration. So this session builds on the findings from the National Neighbourhood Health Service Simulation, which was held at our recent NHS Providers Annual Conference, and it demonstrated the potential impact of shifting activity from hospital to community, from analogue to digital, and also from treatment to prevention. So before we begin, I'd like you to note that this session is being recorded, and the recording will be shared with attendees afterwards. So without further ado, I am delighted to be joined by our expert speakers today. So we have Claire Kennedy, who is the Joint Chief Exec of PPL. We have Dr. Tom Oakley, Chief Executive Officer of Feedback Medical, and also Dr. Indra Joshi, who is Chief Development Officer of Optum UK, all who were really instrumental in leading our fantastic simulation in Manchester. We have a packed agenda, so without further delay, we will get started. So Claire, over to you. Thank you.
Thanks very much, Louise, and welcome to the event, everybody. I'm just going to give a very quick overview of what the simulation is, for those who haven't experienced this in practice. And I'm going to start off by saying it's a very real thing. So we were very privileged at the Providers Conference to have Secretary of State visit. And one of the moments that really excited us all was the point where he said, oh, actually, this is a real thing. These are real human beings. This isn't just sort of pieces of paper being passed around a desk. And I think that sometimes when people think about simulations, they see it in that sort of slightly more conceptual sense of documents being passed around. The national simulation was a very real event with 100 real human beings in a room operating and having the opportunity to what we describe as step into the future or touch the future by operating in the way that we would envisage in the Neighbourhood Health Service. When we're talking about neighbourhood health in this context, what we're talking about is a whole system, whole person approach to the delivery and the experience of health and care. So those 100 people were playing roles that encompassed the whole of what we can consider the traditional health and care sector. So we had hospital, acute hospital, community trust, GPs, etc., etc. We also had colleagues from the voluntary sector. We had colleagues from across local government, wider local public services. So I will have missed somebody in that list, for which I apologise, but I just want to make clear that there were colleagues from a whole range of different elements that make up, if you like, the local kind of public state within a particular community. And most importantly, we had volunteers who were playing residents, and each resident had a particular story that they brought into the simulation. So a particular set of circumstances, a particular set of health needs and conditions that would lead them to interact with this incredible range of health and care partners. The residents had houses which were simulated as small kind of almost rooms that were built within this simulated environment. And again, the environment itself was constructed within the Providers Conference. And all of this is designed to create a space within which people are able to genuinely step into a different world. I know that Tom and Indra are going to talk about the technology that people had access to, which was another part of really enabling the reality of the experience. So what we're asking people to do is not to pretend, but to experience their own experience and expertise and way of working in a different context. So in the simulation, with the exception of the residents, people aren't playing roles. What they are doing is bringing their own professional expertise into a new setting. So GPs are playing GPs, social workers are playing social workers, social prescribers are playing social prescribers. The colleagues who participated in the national simulation had a particularly challenging task because they didn't know each other before the event. So people had to come together and really build trust very quickly between themselves to work in quite a different way. But again, having the physical environment set up and the support from the teams around them really helped people to step into that different way of operating and connecting. The way it works is we have 2 cycles. So within the first cycle, people are encouraged to step into the new way of working. We expect that within the first cycle, what will happen, this happens every time we've done this, is what we all try to do a kind of better version of what we do every day. So people almost stay within the current world, but try to do the current world a bit better. Usually what we find is that although there are elements within that frame that create some form of improvement, actually what you get is an experience which doesn't deliver what people want from a delivery perspective or from an experiential perspective. We then have a really quite important moment within the simulation where people step back and reflect together on what they've learnt from that first experience. We talk in the simulation about the importance of curiosity and connection as examples of things which really kind of build that sense of understanding, and also courage. So the courage to kind of try something new, have a different experience, to really just do something they wouldn't normally do. In the second cycle, what people have is the opportunity to really apply those principles, because they've had the ability, the confidence that comes from doing it once, to then try out different ways of working and connecting. And that is really where we start to see the real differences in terms of the experience that those in the resident roles feel, and the difference in experience from a delivery perspective and a planning perspective. The one final thing I would say about the simulations that are quite unusual is that they operate on both a planning and a delivery layer. So when I say that we have people from all sections of the kind of local public service community, we have a borough council. Well, we have a borough which has within it the local authority, all of the sort of strategic leadership, and that group is meeting and making decisions and making funding allocations throughout the simulation, and those decisions and allocations are having a material impact on what's available within the delivery layer, which is colleagues who are delivering within, in this case, the borough of Ashburn, which was the name we gave to the borough. So there's a very live interaction between planning and delivery. I'll talk about that a bit later, I think, because one of the things that comes through really strongly from whenever we've done the simulations is that the degree to which the real resident perspective is present in those conversations enhances the richness of the conversations and the quality of the decision making. And that is one of the reflections that has come through from every single person who's participated in that planning layer, that the more you're able to connect those decisions to what's actually happening on the ground, the easier it becomes to be able to see clearly and to make the kind of necessary trade-offs that are required to prioritise and flex resource. I'm going to stop at this point, and then open up the discussion, I think, to colleagues on the wider panel. I know that one thing Louise just asked me to reflect on was things that had gone either kind of interestingly well or interestingly less well than we would have hoped. I think you can imagine that of an experience that crosses over a couple of days, there's an evening's worth of anecdotes of all of the different things that happened. But a couple of things I would pull out that I thought were really interesting. One was around the way the integrated neighbourhood teams operated. So what we've seen previously is each member of an integrated neighbourhood team has some form of identifier. So they're able to identify who's on their teams, because you can imagine there's 100 people flowing around and you're trying to work out who's on your team. Within the national simulation, colleagues chose to take those identifiers off because the identifier kind of showed where they were professionally, not necessarily where they were in terms of their own team. So by moving together and kind of taking those lanyards off, they kind of created a team identity, which was much more fluid. The other interesting point, I think, is around the pattern of referrals. So we saw a massive drop in referrals in the second cycle, which we found really exciting, because what that showed was that where we might see referral as being a point of almost a line, a join between two different teams or entities working together. When people are working together as a single team, there's no need to refer because it's one conversation. I think Tom is best placed to talk about how some of the technology enabled that process of connection, but that drop in referrals pointed to a significant drop of the kind of daily friction that people are managing when they're trying to work together to deliver care, and a huge opportunity in terms of both the experience of delivering the care and also from the patient resident experience, the experience of receiving care and feeling cared for, if you like, by a single team of people, as opposed to that experience of being passed between organisations who are all doing the best they can and doing very well-meaning intentions, but where the person's experience is sometimes that they are caught between rather than being held in one place. Tom, do you want to talk? Is it right, Louise? Do I pass back to you or do I pass to Tom?
Yeah, happy to go to you, Tom.
Yeah, no, absolutely. Thank you. I think that's absolutely right, Claire, and that follows exactly what we saw in the simulation. So we were all working on the basis that if you could align the care delivery around the patient, that would be quite interesting, and that would be the fundamental sort of cornerstone to unlocking a new approach. And so what we did with the technology perspective was to create an environment around the individual resident that had a common view of all of their information, but also the ability to bring the team together around that citizen, and to take that from the point of initiation all the way through to point of conclusion. So the Bleeper platform that we put into this simulation was essentially that, a common view of a resident across all of the different modalities, so across both the healthcare aspects, but also social care, and then a dedicated collaboration environment linked to that view, which all of the participants could come together in. And I think what Claire has highlighted is that we freed those teams to work in a way that they want to work. It was much more fluid, much more dynamic. On the first day, everything was done largely through referrals from one team formally passing and transitioning to another. But by the time that we had the second day, actually everyone was working very dynamically in a chat-based exchange, a sort of rolling conversation around the patient, with only formal referrals at a point where they needed to either bring someone in additionally to that conversation, or where they wanted to formalize a particular direction of travel within that patient. I think it was quite interesting for those who have actually read the report from the simulation. One of the key take-homes, the sort of top priority for the delegates that had participated in the simulation, was a digital connection around a common view of the citizen. And actually the thing that they found least important for working effectively as a neighbourhood team was physical co-location, which I think was a really interesting takeaway. Bearing in mind that during the actual simulation, a lot of these teams were only a corridor apart and could physically move very easily to have those conversations, they really did embrace the dynamism of a digital connection. And I think that really showed the importance of digital connection. It's a much faster way of getting to an efficient neighbourhood model. It's more cost effective, and I think actually is more effective in actually its capability for delivering for the patient and for the citizen. So I will pause there because I know Indra's got some really interesting information to talk about from a digital perspective, which is slightly different to where we've come at it from.
Yeah, thanks, Tom. And I think just reflections on the conversation. And when we think about neighbourhood, I think one of the things people quite often want to see as well is, you know, how do you protect, so to say, that sort of single source of truth or the single record at that point in time, so that when you are connecting digitally, you either as a citizen or as the caregiver know that that information is really, the information is both current and valid and clinically safe. And so a lot of the work that we were doing both with Bleeper and with PPL has been around validating and making sure that information, when it goes back into the record, is the record, the information that is needed. And I think the other reflection really is around, we've talked to Claire and Tom a little bit about the sort of individual, but then how do we start thinking about that population level as well? So when we think about neighbourhoods, how do we really think about looking across a population at the services involved in that? And I think the simulations, I'll probably go back to you, Claire, really showed that there were some good learnings that we could do from a population level as well. You could take a condition like hypertension or cardiovascular disease or frailty, and really by bringing all of those together and understanding this is the cohort that I'm looking after, these are the interventions I need to give, these are then the actions to happen on an individual basis. So it's great to have that population level, but then who does that action and the individual patient care setting in that neighbourhood approach, I think was quite nice to see when we were doing the simulation. I had quite good feedback on some of those. So
Thank
Louise,
you.
to you.
Yeah, some really helpful insights. I was thinking, Claire, some systems will be in different places in terms of their digital capability and the extent to which things are joined up. Where do you feel systems can begin implementing behaviours and processes that the simulation highlighted were keys to success, bearing in mind they might not be there in terms of some of the joined up records and so forth?
So I think it's a really interesting question. I think that I'm a veteran of the e-government programs of the 90s, and we used to talk a lot about the dangers of e-enabling a faulty process. So for older colleagues, you will remember the e-enabling phrase. I think that you have to start with the shared ambition, the shared context, and the understanding of what it is you're trying to do together. And the tools are then the enablers that allow you to do it. So I think that in terms of places looking to embark on this journey, it's really thinking about what are the key challenges that are driving outcomes within the population, within the place, within the areas that we are responsible for. What partners and assets do we have available to us now, today, that we could be using in a different way, and we could be relating to each other in a different way to work together to achieve those things? And that process of really quite important dialogue around agreeing the frame of reference, agreeing the ambition, agreeing what people are trying to achieve, recognizing that it is a whole system journey and a whole system opportunity, really. All of that creates the framework for them being able to identify how to unblock some of the challenges around data and infrastructure. And of course, as you say, people are all in very different places around those areas. But it's that sense of shared ambition, the whole system approach, the process of coming together and having a conversation as peers, where everyone's bringing something different to the table, but all those insights actually add up into a holistic picture of what's required. To link back to the simulation, it's very much what the planning layer element of the simulation allows people to test. And one of the things I think we were talking about in preparation for today was, why would you need to have a simulation? And I think that all the things I've just said are things that everybody is trying to do and everybody recognises as being the things that we need to do. I think we probably don't talk often enough about how difficult those things are to do, because everybody is coming from a different organisational perspective. Everyone's organisational or clinical or professional priorities might look slightly different. And the process of reaching an agreement on where to focus energy and where to achieve impact and what time frame to do that within is actually quite complex and quite difficult. What the simulation does is allow people the space to work through what those behaviours look and feel like in practice. So one of the things I often talk about is the fact that we tend as humans to use the idea of what feels right as a gut instinct when we're trying to make decisions. And for the most part, it's one of the things that is very powerful. When you're trying to do something differently, unfortunately, we lose access to gut instinct as a tool to be able to know what the right thing to do is. And we have to go through a far more laborious process of really looking into that gut instinct and trying to work out what's driving it. So within that space, having the opportunity to kind of test that out in a simulated environment gives people the sense of being able to feel that.
Oh, we lost her.
Have we lost Claire?
Yeah, I think we have.
Okay.
Shall I build on what Claire was saying? Because I think I know what
yes, thank you.
Heading. I think one of the things that the simulation really showed is that actually you should be looking to build for flexibility rather than rigid new ways of working, because actually what the simulation showed was that the teams will organise themselves in a way that suits the resident and the citizen situation best. And I think therefore that flexible nature of the approach allows our teams to do what they do best, which is actually build that care package around the citizen. And that, I think, is another reason why a sort of digital first approach is actually a very strong initial move. I think if you go down a bricks and mortar strategy of physical buildings, you're already baking in structure, which may limit your ability to then deliver and have that sort of organic change in the model, which is what we're really trying to drive.
Thanks very much, Tom. I was just going to come back to you, Claire. Actually, the simulation demonstrated the potential, didn't it, to achieve 25% reduction in outpatient appointments, I think a 14% reduction in unplanned admissions, and 11% reduction in GP demand, which is pretty significant.
Yes.
I just wondered, with all of the different participants, did they have, what was their expectation, and were they surprised by the outcome and the changes in the way that they worked? Is it what they expected? And did they notice the shift in the ways that they were working whilst it was happening?
That's a really interesting
Thanks.
question. So people definitely noticed the shift while it was happening, because you could see that demand was appearing and disappearing in different parts of the system. And obviously it's happening very quickly. I'll just explain a bit about how we get to those numbers, which is that sitting beneath the simulation is quite a complex data model, which models all of the scenarios happening in the simulation, taken up to a population level within the hypothecated population of the borough of Ashburn that we're working within. So when something happens to one person, in short, we can model what would happen if that happened to that one person times 30, 40, 500, however many times that person's scenario might appear within the system. I think everyone went in with slightly different expectations. I think people have different levels of interest in the different aspects of the simulation. So some people are interested in the experience of it. Some people are interested in the financial return. What we found fascinating is that the model was proven by every element. So there wasn't any aspect of it where the model didn't hold up and prove that it could deliver significantly more impactful, significantly better outcomes. There were also some quite powerful figures around people being enabled to work through their conditions being treated and managed differently and earlier. So the increase in economic activity was very powerful. And as you say, those really impressive figures around financial return and activity reduction or relocation, all of which were what we were hoping for and what we were expecting, if I'm honest, in terms of the way the model should work and the behaviours and, if you like, the elements that have been co-designed into how the neighbourhood health service model would work. But yes, really exciting and really interesting findings.
Thank you. I was going to move to you, Indra, in terms of Tom's talked a bit about the shifts that were seen by people kind of using the digital approach and the changes in behaviour around sort of the chats and how that was working. What types of neighbourhood level data would you say are most critical in driving a more proactive population health management approach? Because there is something about need, isn't there? And actually where to kind of focus efforts.
Yeah, and quite often we talk about unmet need. So I guess there are two approaches to that. One is, I talked a little bit earlier about knowing your population. So knowing those people who, for example, are asthmatic or are hypertensive, and making sure you approach them in the way that fulfills all the requirement from that clinical journey. I know people have asked a little bit about sort of the clinical risk as well. So you've got to make sure that you understand the clinical risk of those communications and that you record in the right place the information that ensures that whoever then sees that record, wherever that record might be, is clear that that is the action or the event, so to say, that's happened. And then there is the aspect of that unmet need. And I think this is where we as a health system quite often struggle. We know healthcare, we've got information, but actually going on to sort of the wider aspects of health, there's a lot of information that we don't hold in the clinical record, for example. Like we don't necessarily hold housing data, we might not hold education data, we might not hold benefits data. All of these things sort of add up to that holistic picture of what actually a person is going through when we think about unmet need. And one of the things I think we need to work on as a system is to really bring in, where relevant, those pieces of information or those data. I think that's not necessarily a healthcare problem, that's a government-wide and a sort of a system-wide problem that we really need to do. But then how do you act on it? So who is then responsible for saying, I found this unmet need in a patient? For example, I've got a frail elderly patient. Is it the responsibility of the GP? Is it the responsibility of the caregiver to sort of say, this is what needs to happen next? Is it the responsibility for a pharmacist? I mean, there's lots of different peoples in the out of hospital setting that we could say. And I think just understanding, going back to Tom's point, where just being able to see in a sort of a linear fashion or in a all on one page fashion, this is a snapshot of that patient or that person, really helps you then kind of say, okay, this is the next step. And going back to Claire's point on that behavioural change, sort of acting as one team. So we're not like, well, it's not my responsibility to do that, I've passed it on. Sort of all act cohesively.
Thank you very much. So I'm going to open the floor up to our participants, delegates. So if you have any questions that you'd like to ask the panel, please do pop those in the chat. If there are too many questions for me to get through today, we do commit to come back to you, but be really keen for you to ask anything that you'd be interested about and for us to be able to come back to you on those things. As we give you a little bit of time to think about your questions, I've got another question for the panel, which is, Where should an ICS focus first if they want to see a measurable impact within a year? I know that's quite a big question, potentially.
I'm happy to jump in if it's helpful, just to get us started. I think it comes back to that question about each area being different, but it's about looking at the areas where there is an immediate need and where the solution to that need will come from working in a different way. So I'm a huge believer in secondary prevention as an area of massively important focus, because going back to the point I was making earlier when I dropped off, and apologies for that, it's an area that brings together a whole system, because you need everybody around the table to be able to do really effective secondary prevention. So that would be an example of something in some systems, which would be a really good example of a kind of an opportunity to take a neighbourhood health approach, a fully integrated teams approach. But it will be different in different areas, and in many ways the process of reaching agreement on which is the most important area to start and agreeing that as the priority area to start in is actually a really important part of building that alliance of relationships and shared understanding that underpins the whole journey.
I just would add to that. I think there's quite a lot of low-hanging fruit that you can go after pretty quickly, and I don't think that the digital maturity required for this is actually that far away from where people are today. Joining these systems together is not as difficult as it's often made out to be. And actually, it's quite easy to make digital versions of paper as well. So our platform, for example, it deliberately allows you to take digital copies of paper so that you can work across both paper and integrated systems. And I would say that you could pretty rapidly create an environment where you can work more flexibly and creatively and rapidly trial and test new ways of working if you make that early digital investment. I think the danger will be that typically where we're seeing a lot of particularly NHS monies flowing is to the construction of new neighbourhood centres and buildings, which will take time to deliver. And even if you have got the people into the space together, you haven't necessarily changed the operating model, which is really what we should be focusing on.
Yeah, and I think just to bring the dreaded word money really comes into this. I think every ICS knows where their biggest cost is. It could be operational, it could be people, it could be infrastructure, it could be medicines, and really thinking about that from what do I need to improve? How can my neighbourhood working help me improve that particular cost? And it may not just be, oh, we have to look at the record, we have to look at a healthcare perspective. It might be something different. It might be around, as Claire mentioned, that sort of secondary prevention as well. So I think, data can be great.
Thank you. That's really helpful, and some practical thoughts as well, which again is useful. In terms of the questions that people are posing, there's one here about urgent care and urgent on-the-day needs of residents and how those manifested and are being addressed in the neighbourhood context. Were there any specific lessons learned or surprises that you observed during the simulation in relation to urgent care delivery and the opportunities that the integrated neighbourhood teams could bring?
Claire, do you first?
So we had, we didn't have, it's quite complicated. So we did have some people who presented with urgent care needs on the day. We had one resident who was presenting as homeless, so they presented in a number of different ways at different times. Just going back to the question itself. Sorry, Louise, would you mind just repeating the whole question? Sorry.
Yeah, I think the question was about urgent care needs manifesting on the day and kind of the learnings that came from that.
Yeah, so I wouldn't say we weren't targeting urgent care particularly in terms of the experience, but obviously there was an acute hospital as part of the simulated environment. I'm racking my brains to think in detail about urgent care learnings, and I'm really happy to spend, if it's all right, to spend a bit more time thinking about that and going through the data and coming back. I think what we were looking at, so within the neighbourhood health service model, of course, that's one of the ways that people will present and then be referred through the system and kind of be part of that process of connection. But if I'm completely honest, I can't think of any specific examples from the day. One slightly interesting point which has run across a couple of simulations around urgent care was we encourage people to use 111 and 999 as part of the procedures that residents were given access to. We really struggled to get people to use those numbers in the way that they would normally. So in one of the simulations, we had paramedics ready to go, and they weren't actually being called upon, but they, in a way, in scenarios where they knew they would be called upon within that, in real life, if you like. And so one of the things we did in one of the earlier simulations was really push the urgent care response out into the community much more closely towards where we could see the needs were coming from, and to kind of pull that conversation upstream. I feel I haven't quite answered that question. I apologise, but I'm going to take that away and just come back on that, if that's all right.
Yeah, no, that's helpful. Thank you. There's another question which was about the learnings from how those in regulatory and risk holding functions evolved their approach between the different cycles, and what lessons are there about transferring this behaviour into the real world?
I mean, Tom, I don't know if you want to take a stab. I can add some comments.
Yeah, let me look. Yeah, so I think my initial thoughts on that are, you actually need a single system view to do this effectively. So whilst you're trying to create flexibility for your frontline staff, I think there are some key things you have to do centrally. So you need common data sharing arrangements, and I would suggest that the role of the ICB is probably to create those and have the organisation sign on to them, so that we're not having to create new ones for every organisation and every use case. And I think that would be one of the key enablers that you could deliver. And I just wanted to pick up just quickly on the last question. I think in terms of urgent emergency care, I think we have to be realistic about what we're going to be able to achieve in the short term on that, in that urgent patients are still going to attend urgently. Where I think you might get earlier impact around neighbourhood impact, it is about actually accelerated discharge hospital and back into the community, and preventing some of those deteriorations in the chronic disease population, where we know who those patients are and where you can impact, which will translate in time into reduced A&E and urgent care. But I don't think going into this we should be expecting to see an immediate impact on urgent care referrals. I think that's more of a, once neighbourhood is up and running and we're having impact around disease management and early disease identification, then you'll start to see a knock-on effect of lower emergency cases.
Thanks, Tom. And I guess what you've said perhaps links into one of the questions on a shared data set for social care, mental health, secondary, etc., and primary care. And someone's expressed that there are data sharing concerns are potentially limiting GPs signing up. So how we sort of encourage primary care to be able to do that, and for everyone to see the benefits of that shared data set.
I think it's really important in the context of this. We're very good at evaluating the risk of doing something and the risks of actually sharing that data. We very rarely consider the risks of not doing it. And the fact of the matter is, you cannot deliver effective care to a citizen without data being shared. So I think as part of this discussion, we need to really reflect on what is the risk of us doing nothing or refusing to share this information, as much as it is about the risk of sharing it.
Thank you. This might be one for you, Indra. A question around defining the priority residents to target before the simulation. Did you utilise the population health and wellbeing data to do this? Where did you start in coming up with the residents who were the focus of this? Thank you.
So, I mean, we have a population health platform within Optum, so we use those tools internally within the setting. But I expect that if you didn't necessarily have those tools, is to say, I mean, that there's quite a number of population health measures out there on how do you identify the cohorts. I think the second action is it's great to be able to identify cohorts. So you can say, okay, let's take your asthmatics, for example, can use those with QOF codes, etc. But then what's the action that needs to happen on the back of those identification? And that's one of the things that we're working on, particularly in Optum, is to say we can identify the population, but then going to an individual or a PII level, what does a GP or the pharmacist or the community healthcare worker need to do to be able to identify that person and say, okay, this is the next stage measure. Is it to do another test? Is it to actually sort something out in the community, or is it to follow up with an appointment? And that's really the crux of it. It's great to identify, but it's the action on the identification that really helps change the needle.
Mm, mm.
And
And just going, oh, sorry, Claire.
Just coming on and quickly in terms of the simulation itself. So you're completely right with that question. So the way we modelled the population for the simulation was drawn from the population health data for Manchester as it happened. We had done a similar exercise when we did it in London, and we used the population health data for a normal, if you like, for a normal. So we actually used the JSNA data for a combination of data sources for a normal kind of London borough. We changed that because we were in Manchester, even though we were doing a national simulation, just to get a sense of it being more localised in terms of the areas of need and what resident experience would be like within that setting. And so that helped us to be able to target the areas where we would want to sort of focus the response on, and again allow us to then model from that the workforce you would need to be able to respond through the neighbourhood health service model that, if you like, we were working through to meet the needs of those population cohorts within that geography. I hope that makes sense. It's quite a complex process, but it was basically designed to be as realistic as possible and as grounded in human reality within a particular geography. And the exciting thing was that by working that way outwards, we were able to then look at the workforce in a really different way, because we were able to kind of start from scratch in terms of how you might configure the workforce.
That's really helpful. Thank you, Claire. Tom, linking to what you were saying before, we have a question relating to the kind of anonymised patient information. So presuming that the simulation was based on that, you know, coming up with information about patients, but how would you arrange the data sharing and information governance requirements for if they were actual people across organisations, particularly in digital chat, clinical discussions, replicating into notes and documenting decisions?
Yes, okay, it's quite a lot to unpack in that. So firstly, I think in terms of the sharing of the information, we should have some confidence in the ability to share information. I think it's about the security of the system and the access controls that you have. So you can implement various things like role-based access. So not everyone would have access to all of the information about that patient. They may see smaller sections of that information. But I think the default position should be that we should share this information, and why wouldn't we? I would also say that that data probably shouldn't be anonymized, because it needs to relate to the individual citizen that we're working from. Where you would look to anonymize data is if you were going to do something on a more population health basis, where actually you don't need to identify the individual in question. And certainly in a clinical context where we share information routinely for elective care and outpatients, we don't de-identify that information. We do it in a very safe and secure and highly regulated way. But it would be putting clinical risk in, actually, if it was anonymized, because you wouldn't be able to relate back to the patient. So I think we have to have some confidence in the structures we can put in place to protect that data and protect access to it, rather than trying to necessarily anonymize it. And what was the second part of the question? Sorry.
I think it related, it related to that, around data sharing, information governance, particularly in digital chats, replicating notes, documenting decisions. Yeah.
So the one thing I would say is that we are somewhat obsessed with documentation in health and social care. And actually, one of the things that we found is if you're having a dynamic collaborative chat that is fully auditable and time and date stamped, where you can highlight key decisions, the note can actually become the chat. So the chat can become the note. You don't need to necessarily go and separately put this into a templated form that then goes and sits within a particular record filing system. It can be much more dynamic than that. And actually what you want to do is to try to reduce the documentation burden on your staff. So you want that collaboration to become that clinical documentation without them having to then going and separately summarizing it or putting it into a structured form. And if you do want structured forms, a lot of that information can be pulled through in a very intelligent way and automatically done. It doesn't need to be a manual step for the staff. And I'd say that was one of the biggest takeaways that we saw from that digital collaboration, is that move to an asynchronous way of working, where actually it is a rolling chat-based conversation, and that chat is the record. That is the note of what's happened.
Thank you very much.
And Louise, just to sort of, oh, go on, Claire.
No,
I was just going to say, just to sort of build on the government, I think people do worry about governance. And I think Tom is right on that sort of, user-based access, role-based access control. But actually, purpose-based access control is something that you can digitally enable as well, because you may have, going back to Tom's point on that sort of chat-based record, then you have a purpose as a user to be able to access that information. And that's a slightly different way from an IG perspective and a clinical risk perspective to say, okay, the purpose is the next stage of care in this patient. Whoever is involved in that person's care needs to be able to access that information. And so sometimes thinking about it differently from a role versus a purpose is a way to get around the IG.
Yeah.
Louise, sorry. Is it okay if I just jump in on
Yes.
firstly to correct my own failings in as a panel contributor around A&E attendance, because I have now managed to source the data, which I should have had at the top of my head. But there's data which is in the pack itself, which everyone on the call will have access to. It's freely available. We were sending it out after the session today, but just confirming that what we were able to track was a percentage reduction in A&E attendance across all population groups, a really significant drop around frailty and multimorbidity, but a drop across every population group through the scenarios that we model through the simulation. So my apologies both to all of you and to my data colleagues who will be very frustrated with me for not being able to draw those facts and figures to the top of my mind immediately. So apologies for that. There's one question in the chat which I think is really interesting. Well, there's many interesting questions, but the one about social care providers being at the table. I think that is one of the key questions for us as we move forward behaviourally with this. We absolutely need to have a more mature conversation between the whole range of people who are providing services across the neighbourhood, and recognising that those will come from the private sector, the voluntary sector and the public sector. And we need to be really outcome focused in those conversations. Yes, it's a really complex thing to do because people have implicit motivations which may not align with each other. That said, I don't think we're going to be able to move forward until we're able to get into those really mature conversations. So I think it's a really important point, and thank you for raising it. There was another question in the chat around funding for VCSE, because as people identified, a lot of activities shifted to the voluntary and community sector. I think that is also a really important conversation. It's not an uncomplicated conversation, if we're honest, because the reality is that there are freedoms from operating outside a kind of a more structured context, and so that is also a sense of a different way of working on all sides. So I don't think it could be the case that you could simply just move the money from different places and get to the outcome that everybody is looking for. All of this is a completely different mindset, and I think that the thing I would just really encourage us to focus on is that when we're talking about the neighbourhood health service, we should be juxtaposing it with the National Health Service, in the sense that it's a different way of thinking about our primary way of experiencing and delivering the health and care services that we all need as a population. So every bit of our experience will need to be almost processed through this different way of thinking. And yes, that is complicated, but the reality is that we know that what we're doing now is really complicated and it's not delivering the outcomes that we all need. So I hope that's okay, Louise, just to go a bit rogue in the chat and pick up a couple of points. But I just thought they were important ones, and it was just really valuable to be able to bring them to the table.
Thank you. Yeah, thank you, Claire. We've got one more I wanted to pick up, and there is a further question which I think links into the next section, which is about scaling neighbourhood working and sort of practical next steps. The last question was around the role of ICBs supporting neighbourhoods, given their changing role and the downscaling of ICBs, to focus on strategic commissioning and the reduction in resource in those teams. So I don't know if you've got any comments about that.
Yeah, I'm happy to wait.
Yeah. I mean, I would think it goes back to some of the previous comments we made around the data and priorities of ICBs. It's still I think we quite often as a system, we have a new word for something and we sort of go down that new word. And for risk of sounding, I believe neighbourhood health is another new word, but it's not something we haven't done in the past. I think there's now a challenge and a support from digital systems, from data and more data sharing, so we can actually make a reality of some of the ideas that we had in the past, and we can look at the facts that we can actually change things. But that doesn't limit the behavioural changes that on the ground, how systems are funded changes, going back to Claire's point on VCSE social work, social care. So I think ICBs have a role really into bringing some of those conversations together, to act as a convener, and whether or not they have the budgets then, and to align their budgets to where their population or their systems needs are, is really how I would see it, and then how they can support that way of working.
Thank you. That's helpful. So if we move then to kind of scaling this and practical next steps, I think your thoughts about that, and I think it does link to this last question that we had as well, which is where somebody shared how they've redesigned some services to deliver this approach, but they're struggling to track performance indicators effectively to demonstrate impact and outcomes that will support commissioning and funding decisions. They've asked, is there something from the dynamic systems data model, that feels like it might be you, Tom, that can be used in real time? So something around, in taking practical next steps, which we can come on to, actually want to measure the difference that it's making and the impact. Is there anything you could contribute to that, Tom?
I think this is why it is hugely helpful to be doing this on a single common platform, because it makes it all that much easier to track and to audit. And it links also to that conversation previously about documentation as a result of this. If you are moving to a more dynamic and flexible model where the chat and every touch point is a fully auditable event, actually you can move to a very dynamic way of actually monitoring the impact of that pathway end to end, who's done what to the patient, what's being involved in that particular care article, and then that will allow you to build over time a picture of a typical package of care that's being associated with this sort of citizen. And as we move towards a more patient as owner of budget potential model, and with a more sort of strategic commissioning role for ICBs, that sort of information and data set is very helpful. So I think it's a matter of just getting going with it in a slightly non-NHS, non-social care sort of way. I think we have to have a go and rapidly monitor and iterate and take those learnings and feed in a dynamic conversation with the commissioners and the frontline providers, and gradually we will get to a position where we know broadly what we're spending across various service elements to deliver pretty flexible packages of care to our citizens. But I think a common infrastructure to do that on is quite an important bedrock.
Mm-hmm. Thank you.
Louise, could I just come in on that as well? Just to say, so it's a really common question. I think pretty much everybody is kind of wrestling with it. I think we have this real paradox at the moment that there's a whole lot of things that we know work, and we are struggling to, people are collectively struggling to evidence those in a way which, if you like, talks the language that is required from a commissioning and a system perspective. It's not that either one of those is wrong, it's just they're from two different worlds. So the language of commissioning is talking a different language from that of what we know works and what we're doing. We're doing loads of work on this. If whoever it is in the chat would like to drop me an email, I would be really happy to connect them with our head of digital and data who lives and breathes this kind of stuff, and would love to have a conversation about and share some of the thinking that we're doing around that. It's absolutely key, because again, we won't be able to make this change into a thing that we know works unless we can make it communicate with the world that it's sitting within at the moment. So we need to be able to tell that story in both languages. I hope that's helpful.
Thank you, Claire. So in terms of kind of practical next steps, I was going to ask you if you had any thoughts on where people would start, and actually picking up a question someone's asked around that balance between individualised care and a sort of broader based approach. So they've given the example of asthma. So you could bring together different services focused on asthma, or you could look at an individual and all the comorbidities at once with all the staff and resources. And there's kind of a balance between, if you like, a condition and the kind of wider need and I guess, more holistic approach?
We would
It's
see this in terms of, oh, sorry, Tom.
go on.
No. I was going to say we would see this in terms of kind of layers and, if you like, different circles. So there's one perspective, which is, if you like, the integrated neighbourhood team, which is people who have eyes on a population, and within that population, awareness of the different cohorts that exist within that population. And they're looking at a whole population. That there's some confusion, I think, sometimes around the terminology. So that wouldn't be an MDT in the way that people have used the word MDT. It would be a group of people who understand they have a connection and a grounding within a particular neighbourhood, but it would include people from a hospital consultant to a volunteer potentially working on a particular area. But it's a group of people who kind of have eyes on a particular thing. In terms of then cohorts within that, obviously there'll be some cohorts that might be age-based, but there'll be some cohorts that will be condition-based. And I think one of the things that's quite important is that would vary depending on the population within a particular area. The nature, the size and the complexity of the response will be determined by the number of people who might be within that area who would be experiencing that. So I think the key thing is having a framework that can then be targeted to really match what the population experience and need is within a particular neighbourhood. And that's why a neighbourhood footprint is important. Obviously, neighbourhoods don't exist in isolation. They neighbour each other. They're often people who pass between one or two neighbourhoods, even when maybe even kind of just going to the shops, and they all sit within a place. I think however we define a place, and it's different in different geographies, a place is a really important part for holding some of those examples of things which may cut across multiple neighbourhoods. So you may have people dipping into multiple INTs, multiple condition groups, and making sure that people are able to access the care that they need. It's really complicated, and I feel like I haven't done justice to it in that explanation, but I hope that's helpful, and I'm happy to have a longer conversation about it if that is also helpful.
Yeah, thank you. So in terms of where to start, do you have some thoughts for people?
I think contact us.
Well, I would say quite practically, I mean, a lot of people are doing this already. Governments come in, they tend to have an idea of putting a new badge on something that people have been doing already. And a lot of our GP colleagues will say, well, I've been doing neighbourhood healthcare for 30 odd years. It's just a different way of doing it now. I think going back to Claire's point on an individual level, the GP or the community practitioner probably already does a lot of that coordination. I think it's now, how do we push it to the next level? How we get that data sharing across different systems within government, but also how do we ensure that the payment mechanisms flow? So going back to the VCSE comment, that actually the people who are doing some of the work are being paid accordingly versus a very expensive test that might happen in secondary care, but doesn't really lead to any output. And then I think the other practical step is really understanding the touch points that people have in care. Quite often you might go to 3 different settings for the same condition. So how do you start measuring and tracking those from a population level and from a service delivery level when you're thinking about your neighbourhood teams and your neighbourhood approach, so that you really are optimising on some of your costs and that the right people are giving the right care? Sounds a bit cliched, but at the right time. But as a user, you feel, okay, you've been heard. And we haven't really talked a lot about patients and their role in all of this. And I do feel quite strongly that we need to give some more autonomy. You know, people know what's wrong with them. People quite often understand what's best for them at that particular point in time. You know, they might not want to go to see their pharmacist. They might say, I actually want to go here. So giving them that autonomy and that control, this again goes back to data sharing and IG and risk of what the patient can dictate as well in that particular care pathway.
I was going to say, although my first response was quite flippant, I do actually think it would be well worth people getting in touch with PPL, and the reason for doing that is I think that you need to get all your stakeholders together to what this looks like for you in your locality. And actually, one of the best and most dynamic ways of running that is through a simulation, because then you can iterate in real time, you can work out what works and what doesn't work. And actually, it's a good way of bringing those people together in a sort of real world setting to really dynamically look at it. And then off the back of that, you can start to plan and formalize and then decide what it is you need to go after.
Can I add one thing, Louise? That's right. So just to build on what everyone has said, I think that the place to start is almost get to know your neighbourhood. So we talk in terms of natural neighbourhoods. So agree the geography, look at who is living within that neighbourhood, who are the people, look at what assets are in that neighbourhood, you know, what are the either public estate assets or even wider assets, you know, sort of like the kind of wider infrastructure, and who is working within that neighbourhood now. So across your teams, who's got eyes on that neighbourhood now. Just get to know the neighbourhood, see what's happening. The irony is people can feel the neighbourhood, they can describe the neighbourhood, but it's often not written down anywhere, which makes it quite hard to introduce anyone into the neighbourhood. They have to kind of come in and kind of feel it. And actually part of it is just it doesn't matter. Like, you know, we talk about the neighbourhoods being like I say, natural neighbourhoods rather than being any particular population size. There are natural points where people intersect and connect with each other. That's their human experience. That's a massive asset. And in terms of helping to support people within those places, a whole range of things become available when people know that that is their neighbourhood. And to Tom's point, people are able to work with that idea. So if something is not something they would naturally have thought of as being in their neighbourhood, but kind of it's just 50 metres in the other direction, that's a conversation. It's not about trying to kind of artificially create things, but get to know the neighbourhood, create a conversation around the neighbourhood, get to know the neighbourhoods next door and the ones around, and then, as Tom says, extrapolate all that and get a sense of what the landscape looks like and what the possibility and the opportunity is within that space. I genuinely think that this is, as a way, I agree with you, Indra, that lots of this we've been trying to do for a long, long time. There is a moment here that combines both the political will, the understanding of the scale of the problem, and the technology we have available to us that we never had available to us previously. That does create, I think, quite a unique moment, and the need is so great. So I do think this is an opportunity, and I'm a great believer in hope as a choice. And I think this is a hopeful point within the cycle. And I do think, I'm not a sort of sunshine and roses person, but I do think there is a lot in here that builds on the learning of the last 2 decades that could actually move us forward. And I think it's exciting for that reason.
Yes, I definitely agree. So I've got a final question, and I'd like to bring us back to something you said at the beginning, Claire. So how do you integrate workforce if people are employed by various organisations is a question that's been asked. And I was struck by at the beginning, you talked about curiosity, I think, connectivity and courage. And there was real positivity in the simulation. I had the benefit of being able to experience some of that. It was absolutely fantastic. So I wondered if you could say something about the sort of integration bit about workforce, but also kind of leave us with a sense of how those participants felt in terms of the experience they'd had being part of that simulation, and whether there were sort of takeaways from them. Thank you. I think we might have.
Thanks very much. So in terms of the... Oh, am I still here?
Yes, I can still hear you.
Can you hear me, Louise?
Yes.
Okay, excellent. I was the integration of workforce. I think it is in the first stage behavioural. So managing people to work as a single workforce. We know what the structural challenges are in terms of the different ways people are employed, but in order to move forward, part of this, that integrated workforce is behavioural shift. We have discussed the greater function, which is an organisation that can hold people who are working together across multiple things. We haven't really got time to kind of go through that in lots of detail now, but there are lateral options where it's required and where that minimises risk. But I'd say fundamentally an integrated workforce is a behavioural and managerial opportunity. And I think what people experienced within the simulation, as we've talked about from a workforce perspective, was the sense of being one team and a shared sense of purpose, and that came clearly through the quality. Yes, there were moments of confusion, overlapping responsibilities, all the things that we would expect to see in real life. But by working through those moments of confusion and overlapping responsibilities, like people flooding into a resident's house and finding no order, for example, in the second cycle, people have the opportunity to then work as a team and to think, actually, could I ask you to do while you're in that setting, and then I will be able to go to a different setting, for example. So that sense of shared purpose was hugely powerful.
Thanks very much. That's brilliant. So I think that brings us to the end of our webinar. So thank you to all of our fantastic speakers and to all of you who've joined us today. That's been brilliant. We've heard powerful insights into how neighbourhood working can deliver real measurable benefits, from reducing hospital activity to better resident experiences when supported by shared data, working together with a shared sense of purpose and digital infrastructure. So as I said at the beginning, a recording of the webinar will be shared shortly, along with a link to PPL's National Health Simulation Report for you to read. And there's also a summary article, I think, too. We hope today sparks further conversation and really supports you in making some next steps towards scalable neighbourhood health working, which is a fantastic thing to take forward for the health and well-being of all the communities that we support together. Thank you so much for your time. Thank you. Have a good afternoon.
Thanks, everyone.